Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In today's episode, Dr. Sonal Kumar from Weill Cornell Medical College in New York discusses updates on PBC presented at AASLD 2024. This episode is part of a larger education program titled Keeping Up with New Developments in PBC. For more information on Dr. Kumar and to follow along with the slides, please visit the link in the show notes for this episode. Now let's get started and hear what she has to say about this important topic.
Now, it's been a really exciting year for the field of primary biliary cholangitis because in the US, we've had 2 new therapies that have been approved by the FDA for patients with PBC who have inadequate control with first-line therapy with UDCA. And when new medications are approved, as providers, major questions we ask ourselves are really about safety and efficacy. Are these meds going to change the disease course for my patients? Are the effects long-term? Are there any risks with taking these medications, especially when they are potentially needed for many years or indefinitely? And so the abstracts that I'll be talking about today will really give us more insight into some of those questions and beyond what we saw with the primary studies that led to the approval of these new medications. So let's start off by talking about the ELATIVE trial. So this was the study that looked at elafibranor for patients with PBC. It was a multinational, double-blind, placebo-controlled, randomized phase 3 trial. Patients were eligible for enrollment into the trial if they had PBC and an inadequate response or intolerance to UDCA. They also had to have an ALK phos level that was at least 1.67 times the upper limit of normal, a total bilirubin that was 2 or below times the upper limit of normal. There are 161 patients. They were stratified by ALK phos levels greater than or less than 3 times the upper limit of normal or elevated bilirubin. And they also looked at pruritus scores, and so stratified by a numerical rating scale score of 4 or above. Patients were randomized to elafibranor 80 milligrams once a day or placebo, and then they were treated up to week 104, and there was an open label extension where patients that were in the placebo arm were offered to cross over into an open label trial, and those patients are followed up to week 156. The primary endpoint is a composite biochemical response, and that comprised of 3 components. So their ALK phos level had to be less than 1.67 times the upper limit of normal. There had to be an ALK phos decrease of at least 15%, and the total bilirubin had to be within normal limits. So in order to achieve that primary endpoint, patients had to hit all 3 of those components. Secondary endpoints included ALK phos normalization, and then there were additional analyses, and we'll look at some of these things as well. The GLOBE and UK PBC scores, which are validated prognostic scores that estimate the risk of liver transplant or death after 1 year of UDCA therapy. And these are more comprehensive scores than just looking at alkaline phosphatase levels. They're based on ALK phos still, but it's a more comprehensive score. So you take into account total bilirubin, AST, ALT, albumin, platelets, plus or minus age. And it gives us more insight into transplant-free survival. So these are the baseline characteristics for patients in the ELATIVE trial. The mean time since diagnosis was about 7 to 8 years. There were about a third of patients to 38% of patients who had evidence of more advanced fibrosis. So their liver stiffness score was greater than 10 kilopascals. Or if they had a liver biopsy, there was evidence of advanced fibrosis or cirrhosis on histology. I'd like to point out that the mean alkaline phosphatase level for both groups was over 300, which is about 320 in both of the groups. And a significant percentage of patients had high ALK phos levels at baseline. So almost 40% had ALK phos levels that were greater than 3 times the upper limit of normal. You can see the bilirubin. Majority had a normal bilirubin. Liver enzymes, some were mildly elevated. Mean albumin was normal, and mean platelets were within normal limits as well. So here we see what happened to the GLOBE and UK PBC prognostic scores at the end of the trial. So patients were enrolled in the trial, in the double-blind trial, up to week 104, but the primary endpoint was at week 52. And you can see here there was an improvement in the GLOBE and UK PBC scores that were observed with elafibranor by week 4, and it was sustained through week 52. So this is taking the initial data on alk phos and alk phos normalization, bilirubin, and just expanding it a little more to composite scores that have been validated to correlate with transplant-free survival. So you can see here that we have the GLOBE score, and the patients in the placebo arm had a slight rise in their GLOBE score throughout the course of the trial, whereas in patients that were on elafibranor, there was a decrease in the GLOBE score. And we saw a similar impact of elafibranor on the UK PBC score. So it happens early. By week 4, we notice a decrease in these composite scores, and then it was sustained throughout the entire trial. So it just gives us more information, more comprehensive information on the impact of elafibranor maybe on transplant-free survival in our patient. And when they estimated transplant-free survival rates based on these composite scores, so the trial itself ended at week 52 for the double-blind placebo-controlled trial component of the trial, but they did estimates as to what, if this was extended out to 10 and 15 years, what would transplant-free survival rates look like. By week 52, because of the change that we saw at week 52, there were higher estimated transplant-free survival rates estimated with elafibranor compared to placebo. This is here based on the GLOBE score. And similarly, we saw this with the UK PBC scores. So if you look at the change in biochemistry, so these are the components of the GLOBE and PBC, UK PBC scores, you can see that there was an improvement in multiple parameters, but this was driven a lot by alkaline phosphatase levels. So this is the open label extension data of the ELATIVE trial. So the patients were included for the primary part of the trial was up until week 52. And then at week 52, patients were offered to continue if they were in the active treatment arm or to cross over if they were in the placebo arm. And here you can see that the biochemical response, again, that composite response, an alk phos decrease of at least 15%, an alk phos level of 1.67 times upper limit of normal or lower, and a normal bilirubin. That is that defined biochemical response. And you can see the effect was really sustained throughout the 156-week open label extension. And then if you look just at alk phos normalization, which has become a really important marker of disease activity in patients with PBC, and it's really we've shifted our goals in terms of treatment goals to try and get alkaline phosphatase levels down to normal as quickly as possible and as close to normal as possible, especially in patients who are at higher risk. And you can see here the alk phos normalization by week 52 was at 16% in the treatment arm, and then the open label extension starts, and you can see the alk phos level normalization being sustained. So this really answers the question of a sustained response with elafibranor in patients, at least up until week 156. So here you can see with the open label extension what happens to alk phos levels. So this is just looking at alk phos changes from baseline arm. You can see that the elafibranor arm, alk phos changed from baseline dramatically pretty early on, whereas placebo stayed relatively constant. And then this alk phos change was sustained, if not a trend to even further lowering in that treatment arm. And those patients that went from placebo to crossing over into the elafibranor arm had a similar response with a very quick drop in their alkaline phosphatase levels, and it was sustained throughout the open label extension. Looking at the open label extension arm with regards to bilirubin level, you can see here the bilirubin level was slightly increased in the placebo arm during the double-blind placebo-controlled section of the trial, whereas in the treatment arm there was a slight decrease in bilirubin. In the patients who had continuous elafibranor, that bilirubin level was sustained throughout week 156. And those patients that crossed over from placebo into elafibranor in the open label extension had also a decrease in their bilirubin. At week 52 for the crossover arm, there is an increase in bilirubin, but you can see that the range is very big. And just to note that there are not that many patients in this arm. So this will be important to just follow through 156. So one of the things about PBC that's also important is symptom burden. And we know that pruritus is an important symptom in patients with PBC, and it can really be life-altering, and it can be very disruptive to patients. So this is looking at the change in different itch scores. So in the primary trial, the ELATIVE trial looked at PBC worst itch NRS score, the 5D itch score, and the PBC 40 itch domain. And here, this was also assessed through the open label extension. And here you can see the trend down in all three different measures of pruritus of itch in the patients. And then similarly in patients that crossed over, there was a decrease in their scores as well. So let's move on and talk about the other drug that was approved recently for PBC. So this is seladelpar. So seladelpar was approved based on the RESPONSE trial. So the RESPONSE trial is a double-blind, placebo-controlled, randomized phase 3 trial that was followed by an open label study as well, similar to elafibranor. So their open label study is the ASSURE study. They had similar criteria for entry into the RESPONSE trial: people with PBC and an inadequate response or intolerance to UDCA. Alk-Phos level had to be at least 1.67 times the upper limit of normal. AST/ALT had to be less than or equal to 3 times the upper limit of normal. Bilirubin less than or equal to 2 times the upper limit of normal. There were 193 patients. They were randomized to seladelpar 10 milligrams versus placebo, and they were stratified by Alk-Phos levels greater than or equal to 350 or less than 350, and then also stratified by their NRS score greater than or equal to 4 or less than 4. So their primary trial was for 1 year, so 12 months, and then again the open label ASSURE study. Their primary outcome was a biochemical response, and it was the same composite score, so Alk-Phos level less than 1.67 times the upper limit of normal, a decrease of at least 15%, and normalization of bilirubin. Their secondary endpoints included Alk-Phos normalization and change in pruritus NRS scores. The current subgroup analysis that we'll be talking about today are the change in biochemistries among patients with cirrhosis. So higher risk patients, we want to make sure not only is it safe in this patient population, but we also want to make sure that it works as well, because these are the patients that probably need second-line treatment more than anything. So these are the participants with cirrhosis. So the way they determined whether a patient had cirrhosis, they had to meet at least 2 criteria for cirrhosis. And you can see the criteria. None were based on laboratory findings alone. And you can see the percentage of patients in the seladelpar and placebo arms how they met the criteria for cirrhosis per protocol. 14% in the seladelpar arm had cirrhosis, and in the placebo arm as well. So here we can see the change in alkaline phosphatase at month 12 in patients with cirrhosis. And what it shows is that there were significantly higher Alk-Phos reductions with seladelpar versus placebo, regardless of the presence of cirrhosis. So cirrhosis or degree of fibrosis really doesn't seem to have an impact on efficacy in patients who are prescribed seladelpar. The Alk-Phos levels in patients with cirrhosis slightly increased throughout the 1-year course of the trial, whereas in patients with cirrhosis, the Alk-Phos decreased by 121.4 units per liter. In patients without cirrhosis, we saw a very slight decrease in the placebo arm of 18 units per liter in alkaline phosphatase levels, whereas in the seladelpar arm, it was a decrease of 134.8 units. So very similar degree of impact with seladelpar, regardless of the patients having cirrhosis or not. So as I mentioned, the ASSURE study is the long-term open label extension study for seladelpar in patients with PBC. Patients who were invited to participate in the study were those who were in the RESPONSE study. those patients could continue on into the ASSURE study. But they also offered enrollment into their long-term open label extension study to patients who had participated in the past in some of these legacy studies. The patients that were offered from the legacy studies, they had to have an AST, ALT that was less than or equal to 3 times the upper limit of normal, bilirubin less than or equal to 2 times the upper limit of normal, MELD score less than 12, and no evidence of advanced PBC. So similar inclusion criteria to what we saw in the response study. So if they would have met criteria to be included in the response study, they were also offered enrollment into ASSURE. But they did have a gap because these legacy studies had closed. They did have a gap before they were enrolled into the ASSURE study, whereas the patients in the response study were just continued on. Primary endpoint was a composite biochemical response, same as the response study, and then other endpoints that they looked at included alk phos normalization and liver biochemistries. So here are the baseline characteristics of patients in the ASSURE study. So again, this is the legacy patients and the response patients. Mean age was 58, majority were female. Here you can see the distribution of race and ethnicity, with white being the most predominant. Mean BMI was 27. Those 16% had cirrhosis at baseline, with majority of being Child-Pugh class A. The mean alkaline phosphatase level here was 287. Mean bilirubin was 0.8, and the mean NRS score was 6.3 in patients who had a score of at least 4. Here you can look at the composite biochemical response. So this is over 30 months of the study, and you can see that the percentage of patients that achieved the biochemical response, that composite response, was sustained throughout the open label extension. And then same thing with the alk phos normalization. So through month 30, you can see a significant number of patients had achieved alk phos normalization. And this becomes really important as I mentioned that we are really striving to achieve alk phos normalization in our patients, or at least getting the alk phos as low as possible. So here we can look at the change in alkaline phosphatase and total bilirubin at month 30. So alk phos improvement after 1 month. Here again, we see a very quick response, which is really nice to see. We can get patients' alk phos levels down quickly as possible, and then this is sustained throughout the 30-month ASSURE trial. And then same with bilirubin. We see a slight decrease in bilirubin, and this is also sustained. And I think it's really important with both of these studies that we see these long-term effects so that patients are reassured that this is not a temporary response. And we as providers are reassured that this is not a temporary response. So here is the change in pruritus by NRS score at month 6. So among participants with a baseline moderate to severe pruritus, the mean NRS change was 3.3 decrease. You can see here it's a pretty early response, but even at month 6, there is still a trend towards improvement. So I think, I tried to highlight the important take-home points throughout the different studies as we talked about them. But just to bring it full circle, there are new medications that are approved for PBC, and it's a very exciting time as providers and as patients to help get patients' disease under control and symptoms under control. But we want to make sure that these medications are appropriate, they're safe, and they have long-term effects in our patients. So I think the biggest highlight is that we have now longer-term data beyond the 1-year trials for both elafibranor and seladelpar that show that the effects that we see in the 52-week arm or the 1-year arm of the trial are sustained throughout longer-term studies. And we didn't really talk about as much about safety, but at least in the higher risk patients, the patients with cirrhosis, seladelpar is very well tolerated, but also just as efficacious as in patients without cirrhosis. And then from a point from elafibranor, the composite scores of the Globe score and the UK PBC score show that even beyond just looking at lab parameters, we can hopefully impact patients' transplant-free survival.
Thank you, Dr. Kumar, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, keeping up with the new developments in PBC, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.